Brilliant. A very good evening to all of you, and I welcome you all in this Tuesday PG Clinic session on the behalf of Durg Bhilai Academy of Pediatrics. Today the case will be presented by Dr. MONIKA Jaiswal. She is final year student from Sri Sisu Bhavan Children's Hospital, Bilaspur. And our faculty is Dr. S. Balasubramanian sir, Senior Consultant, Director HOD, Kanchi Kamakoti Child Trust Hospital, Chennai. And our second faculty is Dr. VIJAY MAKHIJA sir. He is Senior Consultant from Bal Gopal Children's Hospital, Raipur. With this, I'd like to invite Dr. MONIKA Jaiswal for her presentation. MONIKA, you can start.
Good evening, all of you. Sir, my presentation is visible or not, sir?
Please make it
is
full
visible.
screen, doctor.
It is not on the screen. Make it full screen. ना अभी नहीं आ रहा है. Full screen कर लो उसको. Make it full screen.
Yes, sir. Yes.
No, if we can't make it to start, it doesn't matter.
It is okay.
If there is any difficulty,
It is not
Good
full
evening.
screen. Yeah.
Good evening to all of you. I am Dr. MONIKA Jaiswal, third year DNB student from Sri Shishu Bhavan Hospital, Bilaspur. I am here to present the case. The general details. My patient, ABC, age 1.5-year-old female, a resident of Reki, Hardi Bazar, Hindu by religion, third by birth order, born out of non-consanguineous marriage, and mother being the reliable source of information, came with the chief complaint of generalized swelling over body since 1 week and decreased urine output since 3 to 4 days. Now, history of present illness. The child was apparently all right 1 week back. Then she developed swelling around eyes and face, which was insidious in onset and gradually progressive. It initially involved the periorbital region to the whole face, and it was more during the morning hours and then decreases as the day progresses. Then after 2 to 3 days, mother noticed swelling of the bilateral lower limbs, gradually progressive from feet to knee, and then in the upper limbs from hand up to elbow. After 4 to 5 days, mother noticed generalized abdominal distension, insidious in onset and gradually progressive with no associated pain in abdomen. Mother also noticed decrease in frequency and amount of urine passed, as initially patient used to pass 8 to 9 times per day, but presently passing 3 to 5 times in reduced amount. There was no history of breathlessness on exertion, no history of recurrent respiratory tract infection. There was no history of jaundice, vomiting and blood in stool, no history of fever. There was no history of recurrent loose stools. There was no history of altered color urine, headache, blurring of vision. There was no history of weight loss, bony pain, blood transfusion, or any skin rash, joint pain, drug intake. No history of crying during maturation. No history of any decreased appetite. No history of pain in abdomen, altered sensorium, or seizures. So, shall I continue, sir? In the past history.
please go ahead. Yeah, 1 minute, 1 minute. Okay, you go back to the, okay, just wait. Before we go to the second slide, go to your first slide of presenting complaints. Okay. What do you mean by the term generalized swelling? Is it correct to use the term swelling? You have said, please go to the previous slide. What do you mean by generalized swelling? Is it the right terminology?
So whole body has edema.
No, it is edema, but parents won't say it is edema. They will neither say it is swelling. So puffiness of the eyelids and limbs and abdomen. I think instead of saying swelling, they only said puffiness and of the face, abdominal distension, and also puffiness of the lower limbs. Okay, right. Please go to the next slide. Go to the next slide. Please go to the next slide. Yeah. What does this sentence mean to you? No, please go to the previous slide. Second slide. Yeah. You have said that child was all right, then developed swelling around the eyes, then it involved the periorbital region, then to the whole face, then lower limb, then upper limb, then hands. What does this tell you?
It's so this whether eye around eye soft tissue is very more, therefore the edema first appear in around the eyes, then
Okay. Early morning in the face, yes, very correct, very correct. Then it progressed to involve the lower limb, then the upper limbs. What does this tell you?
so as the day progresses, the edema will then appear in as the edema progresses, sir, it will appear in the lower limbs and both in the
What do you
upper.
think is the cause for edema from this history?
So it may be due to decreased protein content, decrease or hypoalbuminemia.
No. It only tells you that this could be a renal edema.
Yes,
Renal
sir.
edema. That's
Yes,
all.
sir.
That's all. Okay. And it progressively increasing, isn't it? Go to the next slide. Go to the next slide. Yeah. Then abdominal distension without pain. What is the difference? Why you are stressing on pain?
Because sir, if the pathology is renal, to rule out any complications, I have asked about pain in the abdomen.
What complication did you think about?
So bacterial infection like peritonitis.
How common you get the bacterial infection like peritonitis in a child with like this on day 2, day 3 so fast?
No, sir.
Very,
Not-
very uncommon. Very uncommon. Okay, but still you have mentioned there is no pain abdomen. Okay, right. So there is oliguria when compared to the urination before.
Yes.
What does this tell you? Oliguria, insidious and progressive abdominal distension, preceded by limb edema and preceded by periorbital puffiness. What does this tell you?
So due to decrease in intravascular volume
Tells you
degradation.
that it is renal. It is renal. Okay,
Yes.
that's all. That's all you can conclude. Next slide. Next slide. Yeah. Now you are going to explain why you are mentioning all the negative histories. Why history of breathlessness and exertion?
I have asked his history to rule out any cardiac cause of edema.
Cardiac. Okay, in renal edema, you can't have breathlessness and exertion.
Yeah, we can have if there is a severe edema, sir, that causing.
Okay, it doesn't rule out. Okay, recurrent respiratory infection. Why did you ask?
So due to recurrent, due to also this is due to the cardiac cause, to rule out the cardiac cause.
No, why? No. Why did you ask recurrent respiratory infection? You have said child was all right 1 week back, and suddenly you are bringing a past history of recurrent RTA. What made you ask this question? What disease you wanted to rule out by asking this question of recurrent respiratory infection? Sorry, don't mistake me. I'm arguing like a lawyer. It has no meaning. I don't think it has any meaning at all. Recurrent respiratory infection in a child with apparent level. Okay. Jaundice, why did you ask?
Sir, I've asked this to rule out any liver disease, cause of edema due to any liver disease.
In liver disease, do you think edema will first come in the face, then in the limbs, then in the abdomen?
No, sir. First it
Which liver
appears.
disease which liver disease within 3-4 days will cause something like this? No, it is irrelevant, absolutely irrelevant. In fact, I wouldn't ask any history of jaundice at all with such a short duration. Even hematemesis, I don't think I'll think of a chronic liver disease when you have a child who develops first edema in the face, then in the legs, and then in the abdomen. Okay? Okay,
Yes.
at least jaundice alone you could have mentioned. Recurrent loose stools, why did you ask? recurrent stools.
So to rule out any protein losing enteropathy.
Protein losing enteropathy. Will protein losing enteropathy present with periorbital puffiness followed by pedal edema and abdominal distension with oliguria?
No, sir. Oliguria will not be present, sir. But edema can be present.
Again, I don't think it is relevant. Okay, you could have simply said no history of diarrhea. Then no history of altered colored urine. What altered colored urine you look for?
So bright cola colored urine to rule out any gross hematuria is there or not.
Okay, any nephritis, cola colored urine, agreed. Headache, blurring of vision.
So to rule out hypertension in the patient.
Pardon? Headache,
Hypertension. So
headache and
hypertension.
blurring of vision. Hypertension. Okay. Weight loss, bone pain, blood transfusion, skin rash, joint pain, drug intake. Everything you explained. Weight loss.
So to rule out secondary causes of this are like malignancy.
Malignancy. Which malignancy? Which malignancy? Such a short duration, 3 days. You said child is all right 1 week back. I don't think it has got any. See, why ask about malignancy in a child in whom you are thinking of something? Which malignancy? I don't think it is relevant. Bone pain also, I don't think it has got relevant. Blood transfusion, why did you ask?
Because there is a chance of secondary causes like hepatitis B and hepatitis C through blood transfusion.
Hepatitis C and hepatitis B, HIV. So what? So what? Causing what? Why did you ask? You said child is all right 1 week back. I don't think it is relevant. Again, skin rash. Why did you ask?
Joint pain, skin rash for secondary causes like venoic sclerosing purpura.
Okay, vasculitis. Okay, drug intake. Which drug intake did you keep in mind?
So NSAIDs, rifampicin,
NSAIDs.
phenytoin.
NSAIDs. Okay. Go ahead. Go to the next slide. Go to the next slide. No history of crying during menstruation. Why did you ask?
So to rule out urinary tract infection because they
Do you
may
think
cause
urinary tract infection will present with periorbital edema of the feet and then abdominal distension? Irrelevant, I would say. Absolutely irrelevant. No history of decreased appetite. Why did you ask?
to rule out protein energy malnutrition.
Protein energy malnutrition. Do you think it will present with edema like this in 3 days?
No, sir. Yes.
In a previously well child, as you said, becomes irrelevant because you clearly said the child was well before.
Yes,
Okay, again, you are repeating pain in the abdomen. Of course, altered sensorium and she has probably ruling out hypertension and encephalopathy. Is that right?
Yes, sir.
Okay.
So past history.
Next. Wait, before that, you go to the previous slide. Any history of present illness, you should concentrate on the individual symptom and take the symptom in detail from the time it appeared till you until you start taking history and complete the history. For example, your history suggests that there is anasarca. What are the major causes of anasarca? What are the major causes of anasarca? What are the major causes of anasarca? When a child has got anasarca, this is clear anasarca, isn't it? It involved the face first, then the lower limbs, then it has involved the abdomen. With oliguria. What are the causes of anasarca in a toddler? Please go ahead. Anybody can put in the chat box also other PGs.
It may be due to some renal pathology.
It may be renal. Very
It
good.
may be due to hepatic causes.
Hepatic to
It may be due to any cardiac causes,
cardiac causes. Then
or if there is any protein energy malnutrition
pro-nutritional cause. Anything else?
and anaphylaxis.
Rarely you may get due to allergy also. Angioneurotic edema. Angioneurotic edema. Or it may be, if it is in the lower limbs alone, you can think of a lymphedema. Sometime in the lower limbs as well as upper limb, if there is some condition which causes something like a superior mediastinal obstruction. That is very, very rare.
Yes.
Very rare. Very, very rare. Okay. Right? Okay.
Yes.
Okay. Right. So renal, cardiac, hepatic, nutritional, right? And probably angioneurotic edema, or rarely a venous obstruction or lymphatic obstruction. Okay. Dr. Vijay has put in the chat box anemia. Yes, anemia can cause anasarca by causing a cardiac failure. Anemia doesn't cause edema without a cardiac failure. Nutritional, yes, hypoproteinemia, you already mentioned. Hypoproteinemia like kwashiorkor or protein-losing enteropathy, right? In this history, are you sure that the other causes are unlikely? You are sure this is only renal?
Yes, sir.
Yeah, it looks like that. It looks like that previously well child. Okay, right. This is where your history, you could have started with the statement, this child was completely well before the onset of the illness without any serious previous illness, indicating that everything had been normal. That straight away would have ruled out a nutritional cause or your protein-losing enteropathy or anything like that. Okay, right? Okay, go to the past history.
No history of similar complaint in past, and no history of TB contacts.
Why did you ask TB contact? Do you think this is tuberculosis? This child is having tuberculosis?
No, sir.
Can tuberculosis cause anasarca?
No, sir.
Why not? Tuberculosis can cause protein-losing enteropathy. Rarely, tuberculosis can also cause superior mediastinal syndrome with lymphatic obstruction. Very rare. Chylothorax can occur, chylous ascites can occur, right? Rarely due to tuberculosis, but it's not common. But here, TB contact is very important because here you are thinking of a child who could be having nephrotic syndrome, in whom you would like to start steroid therapy. TB contact is important. Okay, go ahead.
Birth history, so antenatal history was uneventful.
Before that, in a child, if you with this history, you said it is renal. If it is renal, what do you think is the renal cause for this?
So it could be nephrotic or nephritic.
It could be nephrotic or nephrotic. Where do you put your money? Suppose you are asked to bet on one of the two only.
So nephrotic.
Why? Why do you say this is nephrotic?
So first is the age.
Age, okay. Which age nephrotic is commonest?
So 2 to 6 years.
Yeah, below 3 years, 1 to 3 years is the commonest age. This is the typical age for nephrotic syndrome. 1 to 3 years. Maximum occurrence is between 1 to 5 years. Agreed. Okay, that is a major difference between nephrotic syndrome and nephritis. What are the other points in the history from which you can differentiate a nephrotic syndrome from nephritis?
So in nephrotic, there will be more edema, but in nephritic, there will be mild edema.
Mild edema in nephritis. Severe edema in anasarca in nephrotic. Okay. Then the only point.
In nephritic, there will be some gross hematuria and hypertension.
Yeah, hematuria, hypertension may be there in nephritis. Very good. Anything else? Anything else? Okay. Now I am going to ask you, which child will be sick? Child with nephritis or child with nephrotic?
The child with nephritic.
Which child will be sick? Child with
Nephritic.
nephritis. Yes,
Yes.
usually a child with nephrotic syndrome, okay, is not a sick child. Except edema, there is nothing else. A child with nephritis will always have systemic features. Systemic features. Anything else? Anything else? Anything else? You yourself said abdominal pain is not a feature of nephrotic syndrome at all. Quite rarely, as you said, nephrotic syndrome can produce renal vein thrombosis or can produce primary bacterial peritonitis and can cause abdominal pain. Other than that, nephrotic syndrome doesn't cause pain, whereas in glomerulonephritis, you might have loin pain. You might have loin pain. That's not very common. Not very common. Okay. What about fever? If fever is present, it favors nephritis or nephrotic?
Nephritic.
Nephritis. And anything else?
So in nephritic,
Anything?
oliguria and edema will present.
History of preceding sore throat or preceding impetigo will favor what?
Nephritic. Sir.
Nephritis. These are all the features.
Yes, sir.
Okay.
Yes.
Right. Okay. Go ahead. Go with your history.
So uneventful antenatal history.
Hmm.
Shall I read the whole history or not?
Hmm.
So first
Please go
trimester.
ahead. Anything relevant in the antenatal
No, sir.
history?
No, sir.
Okay. What relevant history will you take if you are dealing with nephrotic syndrome in a young child? Relevant antenatal history.
So if the mother has a history of fever with rash.
Okay. Any antenatal intrauterine
Infection.
infections. Agreed. Or drug history. Okay.
Yes, sir.
Okay.
So developmental history. So
Normal.
patient achieved appropriate for each.
Okay.
So immunization history. So vaccinated up to date according to national immunization schedule. BCG scar was present, but optional vaccine only PCV was taken. Other was not taken. So
there is no term in literature or as per the ACVAP as optional vaccine. They are all only additional vaccines.
okay.
Okay, there is the term has been removed by the Indian Academy of Pediatrics long time back. It's only called additional vaccines. Okay, outside the UIP schedule or the government schedule. Okay, fine. Go ahead.
So nutritional history. So patient is taking adequate calorie and protein. So family history. Nothing significant, sir. No history of TB contact in family and no history of similar complaint in the family. So
socioeconomic status, class 4. Okay. History is complete?
Yes, sir.
Yeah, I would request Dr. Vijay, please add to it, Dr. Vijay, before we ask her to summarize the history and give us a conclusion. Dr. Vijay, please. Hello, sir?
Yes, sir. Well,
yeah, please.
will you
ahead.
please tell that what vaccines can be given and should be given in a child with nephrotic syndrome, and what precautions we have to take? Sir told that additional vaccines will be required. Which vaccines should be specially given because they are vulnerable to suffer from infections?
So pneumococcal vaccine.
Which one? Which one? Preferably.
So
pneumococcal
if the
polysaccharide.
Child, so if the child is less than 2 years, then we give conjugate vaccine. But if the child is more than 2 years, then we have to give polysaccharide vaccine.
We preferably give the conjugate vaccines to most of the children. So polysaccharide vaccines are almost irrelevant these days. And which other infection is likely to happen and which can be very severe in these patients?
The varicella and influenza.
Varicella, very good. And suppose if the child is on steroids, then what we can do?
So when the child is at alternate dose therapy, then we can give these vaccines.
Yes. What precautions we have to take with the live viral vaccines?
So live virus vaccine should be given after termination of the steroid therapy.
After termination of steroid therapy, suppose 2 milligram per kg was being given, then how long we have to wait?
So 2 milligram. So when the dose is less than 1 milligram per kg, then only we can give the vaccine.
Is there any specific period that we have to wait? If we have to given for 4 to 6 weeks or 8 weeks, then how long we have to wait? Okay, leave this. What is the level of the proteinuria in nephrotic syndrome?
Sir, just 1 minute, 1 minute.
Okay.
All inactivated vaccines can be given. That's first thing you
Yes.
must remember, doctor. All inactive, like for example, you want to give influenza vaccines or DPT vaccines, there is no harm, not contraindicated. Only live
Yes.
vaccine should not be given until these children are off immunosuppressive therapy for at least 1 month. When you say immunosuppressive, which is steroid, but if the child had been on something like cyclophosphamide or rituximab, 3 months.
3 months. Yes.
Please remember
So
these 3 points. One is
So you
all
have to
live
remember the period.
period. Yeah. All live vaccines should not be giving while you are giving immunosuppressive therapy. As sir said, anything more than 2 weeks, you have to stop the live vaccines. The child should be off immunosuppressive therapy for at least 1 month before giving a live vaccine. And the child, if it is on cyclophosphamide or on rituximab, we have to wait for 3 months. 3 months. Vaccines like influenza and other inactivated vaccines, you can boldly give. No harm. Though they may be less effective because of various reasons. Please go ahead, sir.
How will you confirm the diagnosis in this patient?
So first, I will do spot urine protein creatinine ratio.
Yes. When you think that it is abnormal?
So if it will be more than 2, so value will be more than 2.
Okay. Any other test?
So urine dipsticks test.
What it will indicate?
So 3 or more than 3 plus urine proteinuria.
What is the level of the proteinuria in nephrotic syndrome per day?
So more than 40 milligram per meter square per hour, or more than 3.5 gram per 24 hour.
Okay, very good. You can take over, sir.
Yeah, what is your summary of the history? From the history, what do you think this child is having?
So 1 year, 6-month-old female child of birth order 3, born out of non-consanguineous marriage, belonging to class 4, Kupuswamy scale, having all developmental domains achieved and fully immunized till date, with adequate nutrition, and is brought by with complaint of generalized swelling and decrease in urine output. With this, I would like to consider the child is suffering from some renal pathology.
And
Which
what
may
renal
be-
pathology are you thinking?
So it is more likely nephrotic, considering the age.
If it is, and of course, we already discussed the difference between nephrotic and nephritis. Now,
Yes.
my question is, if it is nephrotic, what do you think is the etiology from this history?
So I have ruled out many secondary causes. So it may be due to primary cause, this nephrotic syndrome, because there is no any secondary causes. So it may be.
When will you start thinking of a secondary nephrotic syndrome? With what history will you start thinking of secondary nephrotic syndrome?
So it is more than secondary. So if there is a secondary cause of any secondary, so please repeat the question, sir.
No, when will you start thinking of a secondary nephrotic syndrome? With what history will you start suspecting that this could be secondary nephrotic syndrome?
So if there is any atypical presentation,
What do you mean by atypical presentation?
if it is occurring more than 8 years of age, and if there is
less than 1, more
less
than 10.
1 years.
1 and 10 as a rule of thumb, any infant developing nephrotic syndrome, any adolescent developing nephrotic syndrome, you always think of a secondary nephrotic
Got-
syndrome. Number one. Anything else?
If there is any gross hematuria, if there is a hypertension,
Yes, hematuria, hypertension.
if
Anything
there is
else?
any renal insufficiency, like increase in urea
Somebody has
creatinine.
put in the chat box gross hematuria. Agreed. And symptoms of renal failure, acute or chronic. For example,
extra
anemia. Okay, symptoms of hypertension.
Yes.
Okay, bone pain, etc. You had put in the history. If that is there, you're not going to think of a primary nephrotic syndrome. Yes, some Dr. Vijay is adding renal insufficiency, renal failure. Okay, anything else? Anything else?
Mm.
Anything else?
Extra renal symptoms.
From the history, of course, not relevant in this child. If the child had received medications appropriately and is not responding, for example, you have a child who's
Yes.
being treated appropriately with steroids, good 8 weeks therapy has been given. Then you'll always, it's not responding, you'll always think of a secondary nephrotic syndrome. And somebody has put correctly in the chat box, any extra renal manifestations.
Like joint pain, rash.
For example, a rash, arthritis, anemia, thrombocytopenia, purpura, right? Fever. Fever itself is rather unusual as a manifestation of primary nephrotic syndrome.
Yes.
Unless it is a nephrotic syndrome which has been there for quite some time. Child is on immunosuppressive therapy, then you are going to think of source of infections causing fever. Okay, right? Child, as Dr. Vijay has put in the chat box, child who is not responding to therapy, you're going to think of a secondary nephrotic syndrome. Okay. More importantly, if the child has failure to thrive before the onset of nephrotic syndrome, you're always going to think of a primary nephrotic syndrome or a secondary nephrotic syndrome. Secondary nephrotic syndrome. Chronic systemic disease. Okay.
Yes.
Some systemic disease now affecting the kidney. For example, your lupus erythematosus, right? Those are the clues to make you think that the nephrotic syndrome could be secondary rather than primary. Okay.
Yes.
Go ahead. Sir, have any more questions before we move to the history, physical finding? You can always feel free to ask questions, Dr. Vijay. Yeah, please go to the physical findings.
So general physical examination. Child is conscious and playful, lying on bed while examination. Generalized edema was present. There was no clubbing, cyanosis, and icterus. Pallor was present, and no generalized lymphadenopathy. So this
Generalized edema means, say you could have said anasar, mild or moderate, or from your graph.
this is a picture of the child.
Yeah, I would have said that, okay, moderate, because the face is not all that puffy, abdomen is distant. Okay, feet I'm not able to see. Go ahead.
So
Please go ahead.
vitals.
Yeah, you go ahead. No, please go to the previous slide. General examination slide. Previous slide. Yeah, go ahead.
So weight is weight
No,
for it.
complete that. No. Please go to the previous slide. Yeah.
Generalized edema was present, sir. Clubbing, cyanosis, icterus absent. Pallor was there, present, and so there is no any generalized lymphadenopathy.
What is the cause for pallor?
So
The child
pallor,
anemic and pale. Wait. Is the child anemic and pale or not anemic but pale? Is there a difference between the two?
yes, sir. So due to edema, the child may be not anemic, but pallor will be present.
Yeah, that's very, you could have mentioned that. You should have mentioned that, because you can have pallor without anemia whenever there is an interstitial edema.
Yes.
Right? Okay. Any edema will make the child look pale. Even the hemoglobin levels may not be high. So you necessarily have to look at the mucous membranes to differentiate anemia and pallor due to edema. So you could have very well mentioned here that the child was not anemic, but it was pale. That will make you differentiate anemia causing pallor and edema causing pallor. Please go ahead.
The vitals.
Hmm.
The temperature 36.7 degrees Celsius taken in axilla, A febrile. Pulse is 105 beats per minute, measured in right radial artery, regular rhythm and normal volume. No radial and radiofemoral delay. So respiratory is 25 breaths per minute, abdominal thoracic type. And blood pressure is 87/60, mean 52, comes under 58th to 90th percentile, taken in right arm in supine position.
Go ahead.
The head to toe examination. So in the positive findings, there is periorbital puffiness, facial puffiness. And second positive finding is there is a bilateral edema in both upper and lower limb, which is spitting type.
Go ahead.
So now per abdominal examination. On inspection, the shape is distended, flanks is full, umbilicus central position and horizontally stressed, and movements are all quadrants moves equally with respiration. There is no any visible pulsation. Skin over abdomen is normal. No scar mark is there, though there is no any visible vein or visible peristalsis. Hernial orifice is intact and external genitalia is normal.
Okay, please go to the picture of the child. Go back to the picture. Yeah, now there is some finding. The umbilicus is transversely stretched. What does it indicate?
It indicates there is a fluid in the abdominal
Correct.
cavity.
The flanks are accumulating fluid. One. Second, did you measure the distance between the umbilicus and the umbilicus and the pubis? Why? What is the importance of measuring that? Okay, can you understand my question?
Yes, yes, sir.
Does the umbilicus look like it is in a normal position or pushed down in this child?
Push down.
Push down, push down, push down. See, I don't know. If you see carefully, the distance between the symphysis pubis and the umbilicus pubis and the umbilicus and the xiphoid should always be measured to the umbilicus is pushed down due to any reason. This push down of the umbilicus may be due to several reasons. This push down can occur because of organomegaly like hepatomegaly or splenomegaly, or maybe because of bilateral pleural effusion pushing both the diaphragms down, right? So you had to be, in fact, the moment I find the umbilicus being pushed down like this, I would carefully palpate the abdomen for liver and spleen, and also percuss the chest for pleural effusion. Okay, it is pushed down. And sometimes, even without putting your hand on, you can appreciate that there is hepatomegaly or splenomegaly. For example, the umbilicus may be pushed down and to the left if there is hepatomegaly. The umbilicus may be pushed. You can appreciate even without touching hepatomegaly or splenomegaly, even without touching by looking at the umbilicus. That's what I wanted to drive home. Okay, go ahead. Go to your presentation.
No palpations, sir. On superficial palpation, there is no local rise in temperature or tenderness. There is no guarding and rigidity present, and abdominal girth was 47 centimeter. On deep palpation, sir, liver and spleen are not palpable, and kidney was not palatable.
1 minute, 1 minute. A child with nephrotic syndrome, liver and spleen are significantly palpable. What are the possibilities? child has nephrotic syndrome, but the
Okay.
liver and spleen are significantly palpable.
Liver and spleen. So, in the secondary cause of nephrotic,
I
like
don't see a child has nephrotic syndrome, but liver and spleen, hepatosplenomegaly is there.
the decompensated
Yes.
hemodynamics.
Very simple. Hepatosplenomegaly, if it is present, you should start thinking of causes like HIV,
Secondary.
hepatitis B,
Yes.
C, intrauterine infections. Somebody has put quartan malaria, Plasmodium malaria, causing membranous glomerulopathy, right? Collagen vascular disease, SLE, right?
Yes,
Or rarely secondary to chronic nephrotic syndrome, you can have even amyloidosis causing hepatosplenomegaly, right? These are the possibilities. And Hodgkin's lymphoma can very well cause nephrotic syndrome. These are all some of the rare possibilities. Right, go ahead.
On
Please go ahead.
palpation. So liver span is 6 centimeter and shifting dullness is present, sir. On auscultation, sir, 10 to 15 vowel sound heard per minute in all 4 quadrants, and there is no any abnormal sounds. So other system, so in
What
respiratory.
about genitals? What about genitals? Your nephrotic syndrome abdomen examination is incomplete without examination of genitals.
So it's same.
Normal. Oh, fine. Okay, go ahead.
So other system, respiratory system, normal vesicular breath sound.
Boy or a girl?
The girl.
Okay. Yes, Dr. Vijay is putting in the chat box scrotal edema. That's what genitals and edema, the scrotum, penile edema are very important finding. You can't afford to miss. Go ahead.
So in respiratory system, normal vesicular breath sound was heard, sir. Bilateral air entry was equal, no added sound. And in cardiovascular system, S1, S2 heard, no murmur was there. And in central nervous system, patient was conscious, oriented, and playful, sir.
Okay. Go ahead.
So now summary.
Hmm.
So 1 year, 6-month-old female child of birth order 3 born out of non-consanguineous marriage belonging to class 4 Kuppuswamy scale, having all developmental domains achieved and fully immunized till date with adequate nutrition, was brought with complaint of generalized swelling and decrease in urine output and septic dullness present. With this, I would like to consider the child is suffering from idiopathic nephrotic syndrome with ascites without any complication.
Right. If it is okay, I entirely agree with you that the most common nephrotic syndrome, there's absolutely no doubt. I don't think there is in this child with the normal blood pressure, no hematuria, not a nil child. In fact, in the initial statement, you could have mentioned that this child is this child well looking or ill looking?
So well looking.
Is the child by appearance well looking or ill looking?
Well looking, sir.
Well looking. If you could have
Yes.
mentioned that ruling out straight away secondary cause of nephrotic syndrome or even glomerulonephritis. Okay. Now, what do you think? What do you think are the possibilities other than idiopathic nephrotic syndrome in this child?
So it may be also nephritic cause.
Nephritis is straight away not there. You don't get nephritis in a toddler. The closest differential diagnosis is only a congenital nephrotic syndrome. Congenital. I don't think you have any other diagnosis in this child. In congenital nephrotic syndrome, you start thinking of when the onset is below 1 year, when the infant is failing to thrive, when the infant has got other manifestations giving a clue that there may be growth retardation or intrauterine infection or organomegaly or Hematological complications like severe anemia, thrombocytopenia, or deafness. Finnish type of nephrotic syndrome could be associated with dysmorphism and deafness. You're not going to think of, okay, let me ask you, how do you proceed to investigate this child? This is straightforward, the exam case, short case, or whatever you call it. Please tell me.
So first I will do urine, spot urine protein creatine ratio.
Yeah. What is the usefulness of spot urine protein creatine ratio? Do you do it for initial diagnosis or later?
So first I will do urine analysis, routine microscopy, and urine
Yeah.
dipstick test.
Basically, the point that you must remember, the so-called spot urine protein creatine ratio, where if you get a value more than two protein creatine ratio, it is more useful to diagnose the relapse of nephrotic syndrome than for primary diagnosis of nephrotic syndrome. For primary diagnosis, either you have a urine dipstick showing heavy proteinuria. By heavy proteinuria, you mean more than 1 gram per meter square per day. More than 1 gram per meter square per day. Okay. So that is what you should do. You should do a urine albumin. What about your other tests in the urine? What about deposits in the urine in nephrotic syndrome?
So can you repeat the questions?
Deposit. So what about urine? What about urine deposits, microscopy?
So urine microscopy, there will be no sir hematuria, no RBC will be there. And
Pardon?
so in urine microscopy, there will be no RBCs in the nephrotic, sir.
No RBCs at all.
And so
See,
sometimes
for every rule in medicine, there are exceptions. You must remember that 10% of minimal
Yes.
chain disease causing nephrotic syndrome may have associated hypertension, may also have hematuria, microscopic hematuria. And you may even have leukocytes in the urine. You may have fat cell cause.
Yes, sir.
Gross hematuria does not occur in idiopathic nephrotic syndrome. It occurs only in nephritic nephrotic syndrome. Okay. What else will you do? What other tests will you do?
The chest X-ray.
Before chest X-ray, next
The
to protein,
serum-
what else will you do?
Serum cholesterol, sir.
Serum cholesterol. What is the cutoff for serum cholesterol?
Sir, 200, so more than 200.
Okay. 220 or 200. Okay, fine. Go ahead.
Serum albumin,
What
sir.
else will you do?
Serum albumin,
Serum albumin less than 2.
2.5.
Okay. What else will you do? What else will you do? What other investigation will you do?
The other is a chest X-ray. And
Chest X-ray. Before that, will you do complete blood counts?
yes, sir.
Why do you do complete blood counts? And what are the clues that you will get for decisions in treatment? Usually, complete blood counts are normal. Suppose you get in the complete blood count, the hemoglobin is coming as 15. PCV is 45. Hemoglobin
Yes, sir.
15, PCV is 45.
So there is
What is the test?
hemo concentration is there, sir.
Why is that important? Why is it important to pick up hemo concentration?
So hemo concentration is important because it will because
Why?
due to
Why?
increase intravascular volume depletion, there will be, sir, complication arises like hypotension and oliguria and
More important complication?
thrombosis, sir.
Thrombosis.
Yes, sir.
The moment you see a PCV is rising, you
Yes,
should
sir.
be careful. Even if there is anasarca, you should resist the temptation to use diuretic.
Yes.
Okay. If you give diuretic to a child with nephrotic syndrome who's got severe anasarca, whose PCV is going up, already the intravascular volume is depleted. By giving diuretic, you are going to increase the risk of thrombosis. So you should not be giving a diuretic at all. That's the important. Of course, blood counts are very important because it may give you a clue to the presence of an acute bacterial infection.
Infections.
Okay, what else will you do?
So urea creatinine, serum urea creatinine.
Okay. Then
And so
what else will you do?
USG,
X-ray. In addition to X-ray,
the Montauk's test.
Mantoux test. What do you look for in the X-ray chest?
So I will look so to rule out TB infections, or if there is any pleural effusion.
Okay, bilateral pleural effusion can be picked up. Of course, clues to evidence of TB. So you are careful about giving steroids, right? What other investigations will you do?
So renal sonography, USG, ultrasonography.
What do you look for in the ultrasound abdomen? Why do you do ultrasound abdomen? That if you look at the IAP guidelines, there is no need for any ultrasound at all. Ultrasound, what do you look for? What are you looking for in the ultrasound? Huh? The only clue you may get in the ultrasound is a clue to differentiate nephritis from nephrotic syndrome. For example, the corticomedullary distinction, okay, is lost if there is glomerulonephritis. One. Second is rarely you may end up picking up a renal vein thrombosis, which is a rare complication of nephrotic syndrome. Other than that, ultrasound itself does not pick up anything in nephrotic syndrome per se. Right? Go ahead. What else will you do? You have done Manto, X-ray. Somebody has put in the chat box HIV, HBsAg. I don't think it is routinely required. HIV, HBsAg, and HCV, because nowadays, universal screening for HIV takes place antenatally. So unless you are thinking of a secondary nephrotic syndrome or immunodeficiency, you don't have to do all these tests routinely. Or you are thinking of a membranous glomerulopathy in whom you are looking for causes like hepatitis B or C, you don't have to do any the routine testing. Okay, like what are these are the bare minimum tests that you do for in a childhood. Now, so basically you must remember urine routine analysis, spot protein creatinine ratio or 24-hour protein, cholesterol, albumin, complete blood count, renal function test, Manto X-ray test is good enough. Okay, what are the reports of this child?
Urine routine microscopy, albumin was 3+. So RBC nil.
Okay, no significant deposit. So this looks like a typical minimal change disease.
Yes, sir.
Yeah, go ahead.
So in CBC, hemoglobin 9.9. And so hematocrit is 31.
The only thing is, in your area, if the hemoglobin is very low, you always think of a sickle cell nephropathy, however uncommon it could be. We don't see, you will all be seeing, right? Go ahead.
The serum protein, albumin is less than 1.4.
Okay.
Serum cholesterol is 338, sir.
Okay. Yeah, go ahead.
So no other investigation was this.
No other. You just stop sharing. You just close your slides. Now, what do you do for this child? What are you going to do for this child?
So
how do you manage this child?
So edema is there. So first I have sodium. I will do sodium restriction, sir.
Sodium restriction. What are the indications of sodium restriction in nephrotic syndrome?
Sir, if there is
First,
edema,
please get rid of your concept of sodium restriction for all cases of nephrotic syndrome. The diet for nephrotic syndrome uncomplicated like this: no hypertension, no respiratory distress, no renal dysfunction, is to give a normal diet with high protein. No need for salt restriction. Salt restriction is in nephrotic syndrome only if there is a nephrotic syndrome, or there is hypertension, or there is massive anasarca. Otherwise, there is no need to restrict salt. Normal diet. No added salt. High protein diet. That is the first concept. You need not restrict either liquids or even salt unless there is gross anasarca or renal dysfunction. Okay. Next.
I will start steroid therapy, sir.
Steroid therapy. What steroid will you give? How do you give? What is the dose that you will give?
The oral steroid in the dose of 60 milligram per meter square per day for 6 weeks, and then
You will give us a OD dosage or BD dosage.
the OD single morning OD dose.
Actually, previously they used to think that OD and BD are equal. Currently, it is recommended that you better give BD for initial remission. BD or TDS for initial remission. Okay,
Yes,
right.
sir.
Go ahead.
So for 6 weeks, single day therapy, and then then after that, say 40
If
milligram
you
per
start
meter
steroid,
square.
no, if you start steroids,
Yes.
what will you expect from in terms of response to treatment?
Sir, I will watch for, sir, urine protein creatine ratio, urine dipsticks coming negative or in traces or not after steroid therapy.
How early you normally get a response to steroid therapy?
So generally after 10 to 14 days, there is a response, sir.
Most cases, diuresis starts by around 7 to 14 days. Majority of cases, as Dr. Vijay has put in the chat box, around 10 days, majority of cases would have started responding in the form of diuresis. Majority of cases. Okay?
Yes.
Right? What do you mean by remission? What is the definition
Sir,
of remission? Theoretical definition of remission.
the remission. So if there is a early morning urine protein creatine ratio is less than 0.2, or in urine dipstick there is less than 1 plus protein for 3 consecutive days.
For 3 consecutive days. That is what is the definition of remission. For 3 consecutive days.
Yes.
Okay? That is remission. Okay? Right. What do you mean by the term? Say, how long will you wait for the steroids to act? What do you mean by steroid resistance?
So steroid resistance means there is inability to induce remission within 4 weeks of steroid therapy.
6 weeks. 6 weeks.
Okay.
6 weeks of daily steroids, you are unable to achieve remission. It is called steroid resistance. Okay?
Yes.
Right? There any term called partial remission?
Partial
Remission.
remission.
There is a term called partial remission. What is it? When do you use that term? Anybody can put in the chat box, please. Partial remission. Okay. Partial remission is a very peculiar term where you get a urine protein of 1 plus or 2 plus. Okay. And you get a serum albumin more than 3 grams and absence of edema. And that is called
Partial remission.
Partial remission. Okay. Right. What is the usual onset of congenital nephrotic syndrome? Most cases of congenital nephrotic syndrome, when do they start manifesting?
So at the time of birth or within 3 months of
Within 3 months. Majority will have onset within
3 months.
3 months. Okay.
Yes, sir.
Right. Now you have started, and the child is responding to steroids. What do you do?
So responding to steroid. So then,
Responding to steroid. Child has gone into remission.
yes, sir.
Say 10 days albumin free, diuresis has started, edema has subsided. What do you do?
So I will tell the parents about the complication of the steroid.
Go ahead.
So complications like complications like there will be increased feeding tendency, hyperphagia will be there.
Once there is remission, you complete the course for 6 weeks
Yes, sir.
and then switch to alternate day steroid
Alternate
therapy
therapy.
of 1.5 milligram per kg or 40 milligram per square meter. Alternate days. Alternate dose is single. Alternate days dosage is single, given in the morning. It is given for 6 weeks and then stop thereafter. In fact, some authorities consider even
Tapering.
6 weeks alternate day steroid therapy, they taper slowly over another 2 to 4 weeks. This is expected to induce remission for a longer period. Okay.
Yes.
If
Yes.
the child is having only a partial remission, like I said, okay, urine is 2 plus or more, albumin is more than 3, then definitely you'll have to seek a pediatric nephrology advice, pediatric nephrology opinion. Okay.
Yes.
Will you do renal biopsy for this child?
For this child, I would not do, sir.
Will you do renal biopsy for this child?
No,
In whom
sir.
will you do renal biopsy? In whom will you do?
If the age of presentation is less than 1 year or more than 10 years, sir.
Okay.
If there is any gross hematuria,
Okay.
if there is a hypertension,
Okay. The indications are persistent hematuria or
yes, sir.
gross hematuria, acute kidney injury despite volume replacement,
Yes, sir.
systemic disease features like fever, rash, arthralgia,
rash,
etc. C3 being low. If any child with nephrotic syndrome, if the C3 is low, it indicates there is nephritis. Initial or late steroid resistance. Initial or late steroid resistance.
Steroid resistance.
Or if you want to start therapy with calcium inhibitors, you'll have to do a kidney biopsy. These are all the indications. Age is not given as an indication in the IAP protocol for nephrotic syndrome. Age is not a criteria nowadays. Even 10, 11 years, many people don't want to give any they don't want to give any, right? Okay. What are the other drugs? What are the other definitions you must be knowing? What is steroid dependence? What is relapse? What is frequent relapse? What is steroid dependence? What is steroid resistance?
Steroid dependence is, sir, relapse.
Yeah, please tell me.
Steroid dependence is relapse during steroid tapering on a steroid tapering dose or relapse within 2 weeks of discontinuation of steroid therapy.
Pardon, sorry, I was just moving out because there was bad reception in that room. Yeah. Tell me, what is steroid dependence? What is steroid resistance? What is frequent relapse?
The frequent relapse is, sir, frequent relapse if there is a relapse of 2 or more within 6 months of initiation of therapy, or
Okay.
more than 4 or more in 1 year.
3 or more, 3 or more in 1 year. 3 or more in 1 year. Okay. What about steroid dependence?
If steroid dependence, if there is a relapse within 2 weeks of discontinuation of steroid therapy, or relapse when the steroid is given in alternate dose.
2 relapses should occur. 2 consecutive
Two
relapses should occur.
consecutive relapses. Yes, sir.
Okay. What is steroid resistance? We
So
already
steroid-
said 6 weeks.
Yes, sir.
6
Six-
weeks therapy. 6 weeks therapy. What is complicated relapse?
The complicated relapse is relapse with significant complications like hypovolemia and cardiac failure. Like
Okay. Any complication like infection or thrombosis. Now that makes me ask you a question. Why do children with nephrotic syndrome develop infections? Why are they prone to develop infections? What is the pathogenesis of infections in nephrotic syndrome?
the first, sir, there is loss of globulin in the urine.
Which globulin is lost?
Gamma globulins.
Gamma globulin. Okay. Yes, that is
So
1.
there's
2.
loss of complement factors.
Very good. Loss of C3 complements. 2, 3.
And so third is ascitic fluid itself act as a
Any
culture.
edema is a good culture medium. Agreed. Point 3.
And there is this opsonization.
Opsonin is lost in the urine. Point 4.
And other than
Okay. There are few others. One is that when there is massive anasarca, the intravascular volume in nephrotic syndrome is depleted. This results in reduced perfusion of the spleen, resulting in functional hyposplenism. In spite of the size being normal, spleen doesn't function because of poor perfusion due to hypovolemia. Okay, right? And there is also, Dr. Vijay has put in the chat box very correctly. You are using steroids.
words. Yes.
Okay, you are using steroids and other immunosuppressants. They make the child more prone to develop
Infections.
infection. These are all some of the reasons why they develop infection. What about thrombosis? Why do children with nephrotic syndrome develop thrombosis?
Because there is a increased production of fibrinogen, and so there is increased loss of antithrombin factor,
Yes,
and due to hemoconcentration itself, which
excellent. Hyperviscosity, yeah.
viscosity,
Hemoconcentration.
and there is increased platelet number and aggregation.
Excellent. Platelet function is also affected. Loss of antithrombin, correct, in the urine, right? Okay, right. What are the other long-term complications that you will anticipate in any child with nephrotic syndrome other than infection and thrombosis? Long-term complication.
It may be due to steroid toxicity,
So all the features of steroid toxicity, including growth retardation, 1, 2.
growth retardation, Cusingnoid appearance,
They are
hypertension,
prone for vitamin D deficiency. Okay, they are
hypothyroidism,
hypothyroidism, hypercholesterolemia, future increased risk of coronary heart disease and hypertension due to hyperlipidemia. Okay, all these are well known to occur in children with nephrotic syndrome.
Yes.
Okay, right. Of course, as primary pediatricians, we need not worry about when to use cyclophosphamide, when to use calcineurin inhibitors and newer drugs. I think that is left for the nephrologist. You must know when you should refer. Dr. Vijay has correctly put short stature, growth retardation, etc. as complications. Yes, Dr. Vijay, you have any more questions? Please go ahead. Dr. Vijay, please.
Yes.
Yes, please.
Yes. How will you manage a relapse?
So if the patient is infrequent relapser, then I will give first at the steroid at the dose of 60 milligram per meter square per day until remission. Then I will start after 40 milligram per meter square per day till 4 weeks.
Per day or alternate day?
Alternate day till 4 weeks.
For how long?
So 4 weeks. If it's
4 weeks only.
So if infrequent relapser, then 4 weeks. But if the patient is frequent relapser, then I will go to tapering doses of 0.5 to 0.7 milligram till 6 to 12 months.
This is important. We can use alternate day schedule for a longer period because the patient is not happy when they are coming with the same problem. When you cured him for the first time, then they are happy, but they come again and they are aggressive. They tell you, you are not able to treat. So you have to initially tell them that this is a relapsing problem. What is the role of levamisole and how to use it?
The levamisole is basically given when there is a frequent relapses, and it is given along with alternate day steroid therapy.
What dose?
It is given in a dose of 2 to 2.5 milligram per kg.
How does it act?
So it is generally an immunomodulator.
Very good. How long it can be given?
It's generally given for 1 year, sir.
Actually, in books, it was given that it can be given for 8 weeks. But actually, the pediatric nephrologist like R.N. Srivastav in one of the conferences mentioned that it can be given for much longer period. It can be given safely for 2 years, 4 years, even 6 years. It is a relatively quite safe drug and helps a lot.
Yes.
What are the problems with the use of the cyclophosphamide?
So cyclophosphamide.
What we should be alert with?
So may cause leukopenia, and it also causes agiospermia. So infertility will be the side effect of the cyclophosphamide.
How much cumulative dose will cause azoospermia?
So cumulative, that's I don't know. So.
The
Achha.
most dangerous complication of that can occur in a child with cyclophosphamide is varicella.
Yes, sir, varicella.
You may have to give varicella immunoglobulin or IVIG
IVIG.
such children, in addition to giving acyclovir, varicella. That's a very deadly complication which can develop, right? In addition to hemorrhagic cystitis and pancytopenia and alopecia and infertility and azoospermia. Okay, right.
So that's why we don't give varicella vaccine while giving cyclophosphamide drugs.
Yes. 3
What
months.
is the role of the drugs like mycophenolate and rituximab?
So it is a steroid sparing agent. It can be used if there is any steroid toxicity or steroid dependent cases of nephrotic syndrome.
Actually, we have to learn about these medicines more.
Yes.
Though as a general pediatrician, we may not require to use them frequently. But these are the drugs which are used quite frequently in many of the diseases where the immunosuppression is required. And furthermore, rituximab can help in the patients
Yes,
who are not responding to anything. Along with the levamisole, what other thing we have to do? We have to continue with the alternate day steroid for 8 weeks.
Yes, sir. Alternate steroid therapy.
How much fluid one can take? You have to educate the patient regarding the fluid intake.
Yes.
What you tell regarding that to the parent? How much fluid the child can take? The child is bloated up
Yes,
and
sir.
having oliguria.
Yes, sir. So we have to maintain the input and output.
How do you maintain?
So we maintain by 24
Maintain
hours
by
output maintaining, and then we give fluid according.
then fluid. How will you calculate fluid that has to be given?
So 400 ml per meter square.
Yes,
Is
very good.
insensible water losses. You have to calculate the insensible water losses as 400 ml per meter square plus the urine output. plus the urine
So
output.
this aspect is very important. It
Yes.
is usually said whenever you are seeing a nephrotic child, we can even advise the patient to get admitted for 1 day to learn all these aspects, to do the urine test regularly, to know the urine output has to be measured 24 hours. And then additionally, we can give that amount only, which is 400 ml per square meter, that we can know by the nomogram. So this is very much important. When we should use the albumin in such patients, which is, I think, quite abused by many of the adult physicians.
If there is a sign of any intravascular volume depletion, then we will start albumin, sir.
Do you recommend to be used in all patients or frequently?
No, sir.
What is the practice in your place?
So we only give if there is any issues like due to intravascular volume depression, like tachycardia or hypotension or decrease urine output.
Severe respiratory distress, severe
Yes.
respiratory distress, where you give 1 gram per kg along with the diuretic.
Yes, sir. Along at the end
Along
of
with
the
the diuretic,
yes,
not without a diuretic. You should give along with albumin, along with albumin. Okay.
What are the other things that cause edema? In addition to the loss of the decreased albumin that decreases the oncotic pressure that leads to edema.
Yes.
What are the other things that cause edema in nephrotic syndrome?
So there is
Can you
one
tell?
overfill hypothesis, which will lead to increased sodium resorption from the distal tubule, which also leads to edema, sir.
Any other thing?
Any other thing?
Where spironolactone will help. I'm giving you a clue.
Aldosterone.
Yes, you get hyperaldosteronism.
Yes.
Whether it is renal or hepatic edema, in both the conditions, when it is chronic, you
Yes.
can have hyperaldosteronism.
Hyperaldosterone. Yes.
Whenever there is a edema, there is a decreased intravascular volume that will activate the renin-angiotensin-aldosterone system.
Yes, sir.
That will lead to sodium and water retention. That's sir explained you. And there is one other hormone also involved. Which one?
So aldosterone.
Coming from the pituitary?
Sir, vasopressin.
Yes. How does it work?
So vasopressin.
Again, there is a decreased volume in the blood
Yes,
that
sir.
stimulates the ADH,
Curative hormone. Yes, sir.
that conserves the water
Yes, sir.
and further dilutes. So it contributes to the edema. Okay? Does the giving of more protein actually raise the protein, or it is a general advice?
No, sir. Generally, increasing protein diet doesn't increase the sir.
What simple things you recommend? Protein powder?
No, sir. So currently, there is no need to having increased protein diet, protein in diet, sir. In the current scenario, sir, there is no need to increase protein in the diet, sir.
Sir, your comment?
Yeah, the normal diet is recommended. High protein diet is not known to help.
Yes, sir.
Even if you give high protein diet, the diuresis will take place because the problem is with the basement membrane leak rather than with the protein intake. But you must ensure that the daily RDA is provided properly to the child. That is what is recommended. And of course, other things you can be asked is sometimes diuretics may be required if there is a respiratory distress due to pleural effusion, or when there is genital edema causing difficulty in passing urination. For example, male child, severe penile edema sometimes can cause bladder distension, in which case you may have to use diuretics. You have to be extremely careful in giving diuretics. The other important aspect of management of nephrotic syndrome is to recognize pneumococcal peritonitis pretty early. Any child with nephrotic syndrome comes with low-grade fever, particularly on steroid therapy, abdominal pain. The immediately you have to start suspecting peritonitis. You have to do a peritoneal tap. And in the peritoneal tap, you have to look for pneumococcus. In addition to performing cultures and gram chain, there's a pneumococcal antigen test which is available, which can pick up pneumococcal peritonitis very fast. And you will have to use ceftriaxone immediately after culture. Otherwise, child will succumb to invasive pneumococcal disease. Okay, right. Sir, anything else, Dr. Vijay?
I think that most of the things have been covered.
Yeah, you very good, very good. Anything else? Any other faculty would like to give comment? Naresh, Kishore, anybody who wants to give in
Sir,
comment?
there is a question, sir.
Yeah.
From Rakesh Kumar. Is there any role of anti-lipid drug in nephrotic syndrome?
No,
sir, there's
currently no. No, there is no role. There is
Yes.
no role. No role. It's
Yes.
not recommended.
What is the ultimate prognosis of the minimal change nephrotic syndrome? There may be relapses, but what is the ultimate outcome?
Ultimately, it's a very few cases there is a relapse.
Very few
As the
people
age
relapse.
increases,
No.
as
Almost
the
all-
age increases, relapses decrease.
Yes, the relapses decreases.
No, the incidence of relapse is anywhere between 40 to 70%. Relapse is quite common. At least one relapse, most children with nephrotic syndrome will get. Okay.
So you have to educate the patient in the first setting that this problem is not going to end by 4 to 6 weeks of therapy.
Absolutely. Absolutely.
It is
Okay.
a long drawn story.
Yeah. Yes, Dr. Kishore, it's
Sir,
over to you.
conclude, sir.
It's over to you. If there are no other questions in the chat box, or there are no other comments from Dr. Vijay, thank
Yes.
you, Dr. Vijay, for joining and contributing very significantly. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Monika Jaiswal, for your beautiful presentation.
She
And excellent
presented
discussion.
very well. She presented.
Yes,
She'll
sir.
get a distinction if she does
Yes,
like
sir,
this in
yes,
the
sir.
exam.
Thank you, Srikant Giri, sir, for your kind support. Thank you, our faculty, Dr. Bala, sir, Dr. Vijay MAKHIJA, sir, for sparing their valuable time with us and enlighten us with their knowledge and thought process. Thank you, all the viewers, all the seniors, colleague, and PG student for your attending this webinar. And lastly, thank you, Yogesh Joshi ji, the whole Juventus group, for providing us this IAP digital platform for academic purpose. Thank you all and good night. Thank you, sir. Again. Thank you. Sir.